Спросили, это как? Он сказал, сейчас поймете, и мы перестаем оперировать больных. Я на него хотел вылить ведро холодной воды. Через 3 года он нам собирается представить абсолютно новый концепт лечения травмобольных. Таль.
Thank you,
Thank
Boris.
you very much.
Thank you, everybody in the committee. I didn't understand what you said, but I hope it was positive. I would speak about something that is quite new. Some topics are not new at all, but I will try to speak a bit slowly that it will be time for translation because some of the things are not established words or protocols. I'm working in Sweden. I'm originally from Israel, and I'm a vascular surgeon. Shortly, I will speak about the endovascular new areas that is coming in even to the trauma, about the EVTM, the endovascular hybrid trauma and bleeding management. It's a new thing, the whole concept, and it's taking over. It's ready in use now and more. About the vascular access, which is the main point about this, and of course the RIBOA, the aortic balloon in trauma. And beyond the RIBOA, some cases and about other activities we're doing. There are some new concepts in trauma. You know, the ATLS came some years ago. Now it's the permissive hypotension. Embolization has been used in the last 20 years and is sometimes the first choice to treat a bleeding patient. You can use a lot of things, particles, onyx, and new things like fill, NBCA, etc. Stent grafts, now the major treatment of thoracic trauma, vascular trauma to the descending aorta is stent grafts. The role of CTA, CT angios, CT is easy to use today, it's very fast, so you can use it more, and of course the aortic balloon. It's already has been used in vascular surgery in the last 20 years and increasing. In Örebro, we started the endovascular period in '96. This is my mentor, Thomas Larsson, and today we're doing all the ruptures, aneurysm, the abdominal aneurysm, we're doing endovascular. All of them 100%. The mortality is quite good. We published this and we're consequent with this. This is the treatment of choice. So to the next question, no, we don't open a rupture. We only treat it by stent graft. This you can do if you have other methods to help you. And this led to the EVTM concept. You need a very good, effective teamwork. You need to keep the patient on hypotension, not to give too many fluids and blood. You need to do CTA very fast, if possible. The CTA time, the CT time in our institute is around 14 minutes for ruptures from the ER to the operation suite. So if you work fast, you can do it. You have to operate on an angio table or sliding table, or how you call it, or do it in a hybrid suite. You use local anesthesia in the ruptures as long as you can. You do percutaneous access, and you use the aorta balloon if you need it. And then other techniques, and this can be used in trauma. This is how it looks in the hybrid suite and in the surgical suite, and you see the axis, different axes in elective surgery. And most importantly, this is the normal surgical suite that becomes a hybrid suite if you have a C-arm, an angio table, and the monitors there. And this is the entrance to our surgical unit. And as you see there are 3 angio tables. All trauma patient comes in on an angio table. No exceptions, never, ever. And this is a reason. This is an elective case, but I think it illustrates what I mean. This is a case that I'm sure none of us want to open. He got just a catheter in the subclavia. This is iatrogenic. And guys, my friends in surgery asked, how do we take it out? This is the patient that is very hard to, he has COPD, other diseases. We don't want to put him to sleep, and I said I don't want to open this subclavia, and I don't dare to take it out on massive pulmonary embolism and anticoagulantia. So what we did is 5 French introducer in the arm, and I put an Advanta stent graft. It took around 20 minutes. This is how you take it out, and no surgery. The principles of EVTM is early multidisciplinary approach, early femoral access, and I put personally, it's only my personal opinion, all major trauma get the femoral arterial access. This is my opinion, even if they're stable. Reboa, or the balloon, if needed, and I will speak about the partial reboa, which is the new thing on the block and the new kid in the block, and of course CT if you can do a CT. Sliding table, always put the patient on angio table, and hybrid in mind. This is how the concept looks. The idea is not to replace surgery. The idea is to use surgery and to help each other, to get some method, to help each other with different methods. The main issues, of course, is the access, and this is a liver trauma, major liver trauma. You got the access in the ER, and you can use it. You can do it blindly, fluoroscopy guided, ultrasound guided, cut down. You use the Steldinger methods over the wire to get in. And in this, I'm pushing very hard, this is my personal opinion, that the ATLS should be changed and it should be access while doing the airway. This is a very strong, my opinion is very strong about it. Maybe I'm wrong. I will show some examples. The aortic balloon I will speak about later on. I call it the revival of the aortic balloon because it's been there from '54, but it's getting huge interest. It's an epidemics of reboa. Until today, around 600 reboa were placed in the world. Now the United States, it's going up like crazy, around 100, 120 reboas, and it's going up like crazy. The indications are not defined, and you can use the balloon in other vessels, of course. These are the zones of the reboa, the zone 1, 2, and 3. I will speak about it later. These are some examples how it looks like. But the main thing about the reboa that you have to gain a vascular access. This is our reboa kit in the ER. This is a photo from the ER while placing a reboa, and this is another patient. But this is not about the reboa. The EVTM means that you can use other methods from vascular surgery or radiology to help you. This is a brachiocephalic ongoing inanimate artery bleeding very close to the aorta. We put a balloon inside a PTA 14 millimeter cordis balloon, and then we did a sternotomy. It was huge amount of bleeding. We put up the balloon, no bleeding, patch plastic. Blunt trauma. This is another guy that got a knife, a penetrating, liver bleeding. I put the introducer, then he started bleeding later on, and then we embolized it. It went very well. This is another case with ongoing CPR, with massive bleeding, and he got also the balloon and embolization. And this is another case of a blunt bleeding in the neck area. You can see how you can put the wire there on the side. It's quite easy, and it can help you if you get in trouble. This is another case of traumatic injury to the subclavia. You can stent it. This is a bleeding from the subclavia. You can put a stent there. Of course, you can open it and maybe should open it, but a wire inside can do it easier for you. This is a case we missed. This guy got a knife. He got a knife in the left carotid, and it's being compressed there, or just between the compressions. And we did angio there. He was dying. We didn't understand why. The reason he was dying was probably that the stab went down into the thoracic area, and we didn't have time to open it. But I think this is the extravasation we see. This is also the limitation of the angiography. This is a stab wound to the back to an old lady. Even in Sweden, there are more and more stab wounds. And this is the solution down here in the video. So you can see it's the descending thoracic aorta. Take out the knife. You put in the stent graft. Then you had to open, do a minor thoracotomy to evacuate the blood. It went well. The idea is early multidisciplinary approach to activate people that can help you. Early femoral access, as I said before, CT angio, if possible, is, in our opinion, very important. Always operating on the angiography table, and reboa as bridge to surgery. And I will speak about it later, but partial reboa or intermittent reboa should be preferred. And the idea is you have different tools. This does not replace good old surgery. And there is a great saying I was taught about, if you don't understand it, open it. which is quite important. We're doing some workshops to try to teach ourselves and others how to do it. And in February, we will have quite an interesting symposium in Sweden where we gather all people in the world that are doing Riboa and these techniques to try to get into a consensus and discussion. Thank you so much.
Very interesting.
Tal, thank you very much for your presentation. Questions, please? Yes, Victor.
Tal, thank you for the excellent report. So I would like to ask, you have a 100 rate of endovascular treatment of ruptured aneurysm. So does it make you nervous to have open surgery for such cases? I mean, for the next generation of for young vascular and endovascular surgeons, does it influence on their open skills?
Yes, definitely. Yes, definitely. And
So what you do to
I
handle
had
it?
this discussion with the Malmö people. Malmö is the other center in the world. There are 3-4 centers in the world that are doing mostly endovascular in ruptures. And one of them told me, one of the experienced guy there in Malmö said, interestingly enough, if you can't do it by EVAR, then it's probably you cannot do it by open. If it's true, I'm not sure, but I'm sure that the surgical skills are not going up anyway. We still open different things, but it's a major problem.
I just make it for understanding. Professor Samakhvalov, who is my chief, is actually usually say that we need to train ourselves and our young generation of our military surgeons. And of course, EVTM is good, and we need to implement it in our clinic. But anyway, we should also train to do open.
Never replace with a catheter. The last case I did, the Örebro, we did a clamshell thoracotomy. I will show it in the next presentation. This is not against, this is another tool and very important to understand.
Okay. Thank you.
Thank you.
Yeah, start. Wait a second. Federica was first.
My question is similar. In pelvic trauma, you said that the Riboa is something that is a bridge to surgery, not replacing surgery. But which is the advantages of Riboa in pelvic trauma against the angiography? Because you stop the bleeding temporarily with Riboa, and with the angiography you can stop definitively the bleeding, arterial bleeding.
We did several cases with parallel. You can have the Riboa in one access, you can use the other access or do a third access to do the embolization. The Riboa, the idea as I see it, is to give you some time. So you can win time for the anesthesiologist to give blood, for the people to prepare, for the other access. You know, the Japanese claim they're doing 10 minutes per organ embolization. So a Japanese, and they can do it, takes 10 minutes from stick to embolization of one side. For me, it takes half an hour, at least. So this time you can win due to your Riboa, and I will show later on, because you can modify the Riboa, which you cannot do with clamp. So that's the main issue. So it's another tool, and we're doing EVAR. We do double balloons in ruptures sometimes. You take one balloon, stabilize, take it down, take another balloon into the graft to continue and try to deflate it slowly. So it's tools to do together. You cannot replace it, in my opinion.
Thank you.
Wait a second. Microphone working? Yeah. I have one question connected with Victor. In my opinion, when you use Riboa in severe injury, bleeding pelvis, and you stop the bleeding, the patient is stabilized, you deflate the balloon, and he's still stable, it doesn't mean I don't do angiography. I still go to angiography. You?
I agree completely. You have to do different things. The Riboa, in general, does not solve anything. More than this, the Riboa might cause hyperkalemia, hyperlactatemia, so you have a lot of problems. This is just a tool to use it. You have to think how to use it, you have to prepare to use it, and when you used it, you have to learn the consequences of what you do. It should not prevent, I'm not sure it should prevent a thoracotomy. The last case I did, we had negative drains bilateral. I did a thoracotomy and it was bleeding on the right lung. So I think you have to go with your clinical instincts, in my opinion, and this is not against surgery, this to help you. Okay. At least in my opinion.
I think endovascular, it's a new method that every vascular surgeon wants to know, learn, and practice on a daily basis. Now, this is obvious what he asked, that the young generation doesn't know how to suture, to make all the surgery, but you can look at it also in general surgery. 20 years ago, everybody was asking what's the indications for laparoscopic cholecystectomy. Nowadays, when you're making an open cholecystectomy, it's a big fest in the operating room. Also, many other stuff. Surgery is going ahead, and I agree with both of you. I'm working in the small hospital, I'm doing a lot of classical vascular surgery, bypasses, and I'm using also endovascular, but this is 100% right. The new generation would not know how to make a rupture, an open rupture, but this is future.
Thank you.
The last real question. I have seen that you have anticipated that indication are most probably the critical point of this technique. According to you, which are the patients that where you perform Örebro? I mean,
Excellent question.
Okay, you put inside. I have seen you bypass the problem because you put inside the needle, so you have the access. Yeah. But how many patients that you have put the needle inside you brought to Örebro? And among them, which are the indication? It cannot be only your critical clinical
judgment.
You're
completely right.
You should have an algorithm.
My dream is to do a study on this, and it should be a double armed on a big center to try to do femoral arterial access on all major trauma, which you have to decide and see the complication. The complication rates of arterial puncture is very low. But it should be done, of course. I'm putting quite a lot of this Riboa, also iatrogenic and other reasons, so I feel very comfortable with it. By the way, you don't have to put a balloon. You put it, it's a catheter. If you take it up, it's a balloon.